Huh?
We are live now, sir.
Good evening to all. This is Chandramohan, ortho physiotherapist from Sri Samraj Physiotherapy Center, Dindivanam, Tamil Nadu. Team EXRX India welcomes you all. EXRX India and Sri Samraj Health Services presents Webathon, a web series. We are enthusing for the world record in the field of physiotherapy, not just counting the topics, but responsibly providing the knowledge for the physiotherapists in India and more than 20 plus other countries. Apart from this, EXRX India is providing online OG consultation for the women's health related issue in association with Dr. Rupesh Peak Health Studio, Chennai, West Bengal, DUSAT Creations, powered by Fitness and Rehab India YouTube channel. EXRX India's 220th topic is EMG diagnosis and virtual rehab will be presented by Ms. J. Kalpana. I welcome EXRX India team members, Dr. Rupesh and Professor Duna. Now I welcome our resource person and request her to commence the session, please.
My voice is audible for you, everyone?
Yes, audible. Rupesh, can you please check whether she is more audible because I hear very less.
Volume is very feeble, ma'am.
It's very feeble. Now it's okay?
Yes.
Yeah.
It's better than before.
Okay, fine. Fine. So, good evening, one and all. Welcome to this program. I first thank Mr. Chandramohan and team for organizing such a wonderful program and making me and such a one part of it in this webinar. Really, it's a good initiative, Mr. Chandramohan. No one has tried such a thing. Really, everyone wants to congratulate you. It's a good try. Go ahead. Well said. Go to the next step. Okay. Congrats. Happy congrats.
Thank you. Thank you so much.
So let me start our program today. So EMG and virtual rehab. Just a minute.
PPT is yet to open, ma'am.
So today our topic is going to be EMG and virtual biofeedback rehabilitation. So let me introduce myself. I'm Kalpana.
Ma'am, we cannot see your PPT, please.
You couldn't see?
No, ma'am. Your PPT window is available here.
Oh.
I can see 3 PowerPoint files. You need to click on screen share and select the PowerPoint file, ma'am.
Screen sharing only. It shows
No, ma'am. You are sharing the screen, but not the PowerPoint file.
Yes.
The window is selected.
Yes, yeah.
Click on screen sharing, then select the PowerPoint file.
I couldn't get you. Sorry.
Okay, ma'am, wait, please. Ma'am, I have stopped your screen share, okay? Now please go to screen share and select the PowerPoint presentation.
Now?
Yes, now it is visible. I hope it is visible for everyone now.
Yes, ma'am. Yes.
Okay. Ma'am, please carry on.
Yeah. So I'm Kalpana, doing my M.P.T Neuro. I completed my diploma in ortho rehab. I'm a certified FES and KNF chiro practitioner. I did my fellowship in radiology. I'm founder and CEO of Physio and Rehab Ananagar and Kodambakam in Chennai. Okay. So before starting into the EMG and visual, both are comes under the biofeedback. Let me just give some introduction about the biofeedback. Then we go to the next level. Then we will just give a brief about the biofeedback. Okay. So let me start with the biofeedback. It's a procedure which is going to take about electronically as well as for some electromechanical instruments also to create a visual signals, not only visual signals and also an auditory signals to make the patient to perceive and to perform the activity. Thus in turn is going to help you to initiate the voluntary control movements. So that in turn is going to be relaxed for the neuromuscular relaxation and it's going to help for the neuromuscular re-education also. This biofeedback helps in two ways. Not only the diagnostic as well as is going to help you in a muscle rehabilitation, which is which is which is going to help you for the next level of the physiotherapy. Okay, the major role of the physiotherapy is going to be produce the information related sensation associated movements. That in sense, once if you perceive anything, patient could able to perceive and not to perform the activity for a lesion, upper part lesion in the case of senses. The patient will say once he is able to receive the auditory signals and sensory signals, that in turn is going to stimulate the cerebral cortex, which is going to stimulate the motor junction, and that in turn automatically develop the muscle activity, voluntary and involuntary and voluntary activity. So let me go to this is the major role of the biofeedback. But giving some goal or objective, making the patient to achieve. So that's going to helpful for the patient for moving to the further level and to achieve the goal. Okay, so definitely feedback is in temporal sense. It's going to occur not only in the moment as well as after the movement has also been achieved. Once it's going to be slowly stimulated step by step, that in turn which is going to complete his normal aerial activities which is couldn't be achieved in a normal life. So this feedback, we have lots of instruments in getting this feedback. So that with the information and with the missions, we are going to go. That is the role of the major biofeedback mechanism. Then definitely it's going to give some small changes in the performance, and there is a lots of rewards. Once you achieve a goal, patients once they get reward, they get a positive feedback. So that in turn it is going to stimulate the patient to go to the next level. So creating a goal and making them to achieve, it's going to create for the next level of movement. So it's going to train with the use of the measuring instruments, and they can practice by themselves, even in home without the help of the physiotherapist also, but with certain limits. Okay, so this instrument, we are going to see about the biofeedback instrumentation. So it's not only going to measure about the physiological event, but also it's going to record and they're going to correlate, they're going to compare on 2 days before how much your activity and how much your muscle joint range, how much your movement, how much your aerial activity was achieved. After a week, there will be a record how much you finished. Compared to the day one, you can easily make the patient to visualize it. So 1 week before, if you're able to reach, the patient is able to move. But after a week, now keep on moving and keep on trying to for a specific level. The patient is after a week, the patient is able to reach the object. So these are the visual feedback which helps the mechanism to move in a further level. Okay, definitely it's going to this biofeedback is going to give indication for the physiological process, but we should not confuse with a physiological processes. It's not going to give, it's going to give an indication how is the physiology, now it has been, how it is improved, but definitely it's definitely going to affect your physiological process. Okay, so in the first we are going to see about the EMG biofeedback today. Before starting the EMG, we have to find out what is action potential, then how the electrical activities have been turned into a feedback mechanism, which is going to help the contraction of the muscle. So how the instrument is going to capture the action potential from the muscle. So usually a nerve fiber conducts an impulse to the neuromuscular junction from the heart, where the acetylcholine is going to bind to the receptors. Okay, so that is going to create a depolarization in the muscle fiber. So that will create the movement of the ions, which will going to create the action potential. So once a nerve fiber there and all, the nerve fiber is going to attach into the muscle fiber, definitely there will be a repolarization. That in turn is going to create an action potential. That action potential electrical activity is going to capture by the instrumentation. That in turn is going to come in the form of a graphical representation in an EMG machine. So this change in the potential differences can be detected by the electrode, which is going to be placed in the muscle fiber. So once the nerve impulses has been innervated over here, the myotendinous junction, the acetylcholine is going to get released, and then the depolarization is going to happen over movement of ions. Thus in turn is going to create the action potential. If you keep the electrode over here in the muscle bulb, definitely there is action potential. The electrode will detect the action potential. Okay, will detect the action potential. That in turn will form in the form of a graph. Okay, so the EMG, be clear, the EMG does not going to measure the muscle contraction directly. It's just going to measure the electrical activity in the muscle. Okay, so what are the electrical activity associated with the muscle contraction? The EMG is going to detect. Okay, usually the electrical activity, it will be 1 volt for usual. Okay, but this may be variant from different person to person, even for the same person to the different sides also. If you detect for the biceps in the right hand, definitely there will be lots of variation in the left side also. Depends on how you contract. How do you have the muscle power? How the electrical activity is getting fired up? All depends on this electrical activity. Even that is going to be varied. Okay. So definitely, another thing is, if you're going to compare the for a single muscle for the same patient, you have to use the same EMG readings can be compared. Because if you use a different EMG of a different EMG on that side and different EMG of that side, definitely that's not going to correlate, and the result will not going to be a clear view. You couldn't get you the clear view. Okay, so this feedback machine receives a small amount of electrical energy, even that is during the muscle contraction, through the electrode. From the electrical activity on the skin also, converted into a type of the information. Okay, most of the EMG electrodes in earlier days, they use as in the needle type of electrodes. Okay, nowadays it's very advanced, it's only very surface. On those days it was very needle. You have to insert into the muscle bulb. That electrical activity is getting converted from the needle to the machine. Then it's going to be form a perfect graph order. Okay, nowadays on those days the machine is really very big to carry. Even we couldn't move. It's almost size of X-ray machine like that. Okay, nowadays it's very advanced. Now we are using only very surface EMG. Only we have to connect the electrodes to the skin. Okay, so you have to do the movements. The muscle contraction will occur. Will capture the electrical activity automatically through the Bluetooth. We have a software through the Bluetooth. It will connect it to the screen. So automatically the patient will visualize once if you contract the muscle. Okay, once if it connected to the, I'll explain you about the placement and all. Once if you contract, automatically graphical representation of how much millivolts the muscle is able to contract. Okay, and the same thing if you want to perform on another muscles also, connect to the other side and contract maximum. How much the maximum can patient be able to contract? Make the patient to contract the biceps or triceps, whichever muscle you want to get it. So make them to contract the muscle, then you will get a clear graph. It's sure how much millivolts you achieve. Then it also shows after how many minutes it's going for a fatigueness. Okay, the people who have a good tone, okay, will have a different fatigueness. The people who will have a good endurance in the muscle power, definitely the fatigueness will be very slow. Okay, so even that also we can find to this EMG. This EMG biofeedback, it's not only it's going to reveal about helps in diagnosis, as well as it's going to help in the muscle rehabilitation too, for the muscle re-education as well as for the rehabilitation though. How it in the sense, we usually study EMG is only for the diagnostic. Even what we bought is only for the diagnostic. Then after that we thought, why don't we use for an biofeedback mechanism as a rehab mechanism. So what we thought is, first we'll start as a diagnostic view. What we'll do is for our patient is, the patient is coming, for example, with the weakness of the or a hemiparesis patient. The patient should have to know how much power has present in the unaffected arm when compared to the affected arm. Okay. First, make the patient to lie down, connect all those electrodes, then make the patient to contract the muscle which has been affected a lot on the affected side. Okay, you just connect the electrode first to the unaffected side, make the patient to move, then you can find out a graph how much millivolts he can contract. Then you just go to connect to the other side, the affected part, again make the patient to contract. So he can visualize how much difference he have to overcome to make the muscle more contract. Okay, so easily the patient will feel, okay, so this much contraction only I can produce. So I have to do a lots and lots of re-education. So then what we'll do is, we identify, we shown the patient, this is the diagnosis, this much volt is differences between your left side and right side. So and then we check which muscle is gone for a lots of weakness and compared on the whole side, and on the affected side. So what we'll do is make the patient to do the exercises, as well as we'll connect to the EMG through the visual, through the TV or to the projector. We'll make the patient daily to make the contractions regularly. So automatically the patient will have a thought to achieve. We'll set a goal. Over there in EMG, in our system software, we can set a goal too. If suppose if there is a contraction for about 80, 90, 100 millivolts in the left side, in the affected side those is maybe 30 or 40. First we'll put a line, make the patient to contract, and the graph has to reach at least for a 30 or 40 for the first day. Okay, so slowly the patient will achieve. Okay, then slowly we can make the patient not only in the graph, okay, in the graph form, we can also make the patient in a visual, like a gaming process like this. If for example there will be a ball, if the patient contracts the muscle, automatically the ball moves. Okay, we'll set a goal. The patient will automatically contract the muscle and make the ball to touch the goal. Then after 2 days, again we'll set another goal. Then automatically patient will have the intention. Yeah, we want to reach the goal. If you give some goal, definitely the patient will try to achieve it. Okay, or simply if you make the patient, you have to do this much, do just 10 counts 2 times. You just try to lift up the arm 15 counts. Definitely the patient couldn't. Okay, if you give a goal, okay, definitely if it is if it's a type of a gaming process, definitely the patient will enjoy the game to do. Therein by the muscle readjustment is going to occur. Okay, so definitely the skin surface. Then we deal about the electrode. The electrode purely it is made up of stainless steel or nickel in a plastic holder, because the stainless steel had a capability to capture the action potential, electric signals. Okay, some electrodes will get permanently attached to the cable layers. So you have to connect every time. You have to stick to the electrode. Some we have a disposable electrodes also. Okay, every time you have to clean out your area with the alcohol rubbish, then you have to keep the adhesive electrodes. You have to connect to the cathode and anode mechanism. Okay, usually we have a set of 3 electrodes, cathode, anode, and neutral, and the machine is this much. I'll show you the machine. This much. The machine size is that's all. This much size. Okay, even you can connect it to the Velcro band with the arms or wherever they feel like. Okay. So before connecting to the electrode, you have to be clean with alcohol soaked paper. Okay, you have to the muscle has to be connected to the electrode should be connected. We have to check whether the Bluetooth is connected to the monitor, and the electrode placement definitely should be very parallel to the direction of the muscle fiber. It should not be perpendicular, because you know the action potential, the sarcolemma, the sodium potassium channel transfers, everything you know. So almost the electrode should be, then the curvature will be like this. The action potential mode will also move in the same form. So you have to capture, then the electrode should be parallel, to be kept parallel to the muscle fiber. And the electrode arrangement, definitely you shouldn't have any noise. Even that is also captured by the electrodes. Okay, two active electrodes and one reference electrode automatically pick up the electrical activity from the motor units fired by the muscle. So this is the machine. Okay, this is the neutral one which is connected to the bony prominence and the cathode anode. Why we should connect it to the muscle fiber, not to the myotendon junction or somewhere else? Because you know action potential and the motor units firing will be more and more on the muscle fibers, muscle bulk. Okay, so then will be the readings will be proper. Okay, so see, almost the same patient, we connected three surface EMG device, triceps, lateral head, neutral, cathode and anode. This is for the long head, cathode, anode, and the neutral. Neutral should be for the bony prominence. And over here, the medial head, the bony prominence over here, and to the muscle bulk, the cathode and anode. So if the patient makes the patient from the flexion to extension, fire up, making the triceps to get fired up. Okay, these three EMG device, okay, will be connected to a software, okay, where three graphs can be seen simultaneously. Three graphs can be seen simultaneously. Even we can check for the lateral head, medial head, and long head with the same muscle. With the same muscle, we can easily understand which head has a strong capability of moving the joint. Okay, the same thing has been done to the plexus group. Here, the neutral one. The machine is completely strapped over here. So the patient, it's not only going to give a static movement, muscle fiber contraction, it's also going to give you about the dynamic contraction too. Okay. For example, making the patient to walk, or if you're making the patient to squat. Okay. Connect one pair to the gluteus, one pair to the quadriceps, and one pair to the gastrocnemius. Okay, the same part can be checked on the other side. So you can clearly visualize, okay, how much contraction is registered in each and every muscle group on the right side as well as the left side too. The patient whose inability to do the squats, some people will have a pelvic tilt, okay, automatically due to the low firing of the gluteus maximus, they couldn't able to get up from the floor. Okay, we can easily visualize. Usually, if we make the patient to do squat, we can identify only the patient couldn't be able to squat. We'll never check whether which muscle is going, which the muscle is not firing to make the patient to go for a squat. Okay, we have to identify which and each muscle. This is going to clearly elicit the how much millivolt contraction is going to happen on the other side and this side. So easily we can identify some people will have right side gluteus maximus weakness with the left side quadriceps weakness. Okay. So this time over doing squatting, going down, this pelvis completely dropped on the right side. While getting up, the left of quadriceps couldn't able to fire up properly. So it doesn't eliminate properly, and while getting up also the patient able to feel a lot of trouble in doing this movement. Here, this is what I said is that this is the innervation zone. The contraction will be this much. So it's not going to reveal a proper, putting the repolarization will be not in a proper way. The EMG graph is known. Over here in the midline offset, if you kept over here in the midline offset, even had to, the potential generated is very slow over here. The graph will not be with a proper, you will get a lot of latency over here. So the contraction will not be proper over here. We couldn't identify it too. If you kept in the myotendinous junction, definitely compared to here, there is no spiking at all. The correct placement is the midline of the muscle belly parallel to the muscle fibers, okay, between the innervation and the myotendinous junction. If you keep in this way, you'll get a proper spiking and you can easily identify the electrical volt potential also. Okay, and you have to do some amplification also. The small voltage detected by each active electrode definitely will respect. There will be a lots of separation in the signals. We have to check for the creating signal fluctuation. The signal variation has to be captured and properly amplified by the amplifier in a proper signal. Okay, then it should be very smooth. Then only the electrical firing and graphical representation also will be very smooth. Okay, so this specific you can easily see in this total area. So it will be completely smooth and there will be a complete contraction. Okay, usually it will provide visual or auditory feedback relative EMG. This visual feedback can be easily analyzed, so by using the light. If you move, if you contract, if the light goes, the patient, oh fine, today I have achieved. If you have a red light glow, okay, fine, I have not achieved that much goal. If you get this orange light, okay, almost I'm reaching the goal. If they achieve the green light, oh fine, today I achieved really. I could make the muscle to recruit it very good than before. So we have a lot of auditory feedback moving also, like keeping a tone or a buzzing. In my software, what they will do is, I said, a ball is moving. Okay, so when you contract, the ball will automatically move up. Okay, if you relax, automatically drop down. Okay, it will drop down and burst. Once if you contract completely, if you set a goal for about 80 words or 70 words, depends on the muscle, it will reach, once it reach the goal, automatically it blows. Okay, it will burst and create and give some sounds. That sounds makes this feedback, that visual and auditory takes that feedback makes the patient to go for the next level. They will feel positive to go, okay, fine, I have achieved today, so let's go to the next level. Patient will come and ask me, ma'am, today I completed this level, please let me allow to go for the next level. So definitely the EMG feedback mechanism is going to act very high. Okay, the high signal means the biosignal used in sensitive is usually strong enough to detect even the small amount of electrical activity. Depends on your the mission. It depends on your EMG mission. It should be highly sensitive. It should be highly sensitive because in case of the very any motor neuropathy cases and all, the electrical activity itself very feeble. Okay. By the time they couldn't be able to detect the signal at all. So the unit what we are using, it should be highly sensitive to find out the electrical activity. Okay. So the muscle clinical application, what I said is it's going to re-educate the muscle. Okay. The neuromuscular control is going to be involved, and which in turn is going to increase the strength of the muscle. Relaxation, definitely. If there is a spasm over the particular group, automatically if the agonist is going for a spasm, automatically the antagonist is going for a relaxation. So what if to control the spasm of that particular antagonist, what you have to go and activate the antagonist, contraction on and off. So that in turn is going to relax the muscle pain as well as the pain education. Pain reduction in the sense, due to the muscle weakness, there will be a lot of compression in the joints. Okay, that in turn is going, if you re-educate the muscle properly, automatically once the muscle has been toned, the joint compression, the stretching is going to relieve the joint pressure, automatically the pain is getting controlled. So this is the machine and this is the charger. Okay, we connect. It's just a simple software which we can connect to the mobile. What we are using in our clinic is the tab or a big computer. Now we are using the thing. So this is, I said, the electrode is made up of the stainless steel. Okay, this has to be connected to the stick electrode to the surface.
Alex, come. Ignacio's contracting his deltoid muscle using a portable EMG device we have.
Even in the deltoid?
Yes.
So it is giving some isolated contraction to the muscle.
C7. Say it, man. Say it. C7. Nerve avulsion of the brachial plexus. And he's contracting the damn muscle using 60 millivolts per second of 400.
Yeah.
That's like nothing. Look at you. and he's keeping it in the grid. Alex! He was like,
Yeah, slowly he's dropping down. So by the way of wave and the hike in the wave itself, the patient feels very positive if he's doing compression. And the command you give, the command the physiotherapist, making the patient to contract. Okay, so this making the patient to move in a further level. Okay, so transferring next to the visual rehab. So everyone knows it's also a biofeedback mechanism. Here in visual rehab, lots of game procedure. Okay. Here there won't be there won't be any recording of the picking of the electrical active potential. Okay. In visual rehabilitation also, certain types of software is going to reveal you about helps in the diagnosis as well as the treatment protocol. Okay. Help you just give you a complete briefing about your muscle activity. Okay. So if a patient couldn't able to feed on his own, definitely there should be biceps activation. Okay. Pronator has to be done. The flexor distal superficialis has to work. Okay. And there will be a flexion with the abduction knee. All together makes the patient to move the hand into the mouth. Okay. So over here, even this has been achieved in the EMG also. If you connect all those things to the muscle which I said, if you connect all the EMG devices to that particular mechanism, makes the patient to control, makes the patient to move and move and move. So you can see a graph. That patient makes this graph makes you to move. If you slightly assist them, it will be able to manage and make the patient to withhold for some period of time to make an isometric contraction. So that in turn will help you the increase in the muscle tone. Then slowly go for slowly toning, strengthening as well as for the endurance activity. Always train the muscle in the aerial activity training, not a simple just a contraction and relaxation. Always makes the muscle even to move in an aerial activity. You have to ask the patient which activity you have to ask the patient which activity you couldn't able to do it in the normal days. In your normal day-to-day activities, which are the activities you couldn't. Some people will person will come in the habitus capsulitis or an tear or a post-op case, couldn't able to comb his hair, couldn't able to clip his hair, couldn't able to brush his hair, couldn't able to wash his face. So according to that, you have to identify the muscle which is going to involve in each and every action moment, then find it out, okay, analyze it properly, then then diagnose it with the signals, okay, then find out how much that electrical action potential has been generated in the muscle. So how much action you can give, how much spike you can give, how much effort you can give to make the movement into furthermore activity. Even we have lots of things, even in the TNF also, we have lots of aerial activity based training in education. So train the patient in that way to reach the aerial level. If you make the patient only reflection or abduction, or if you always coordinated with the complete activity based movement, the patient will feel very successful. Okay. If the patient is coming with shoulder flexion only 0 to 30 degrees, even if they achieve 0 to 90 degrees, they won't be satisfied. The patient won't get satisfied just by lifting 90 degrees. But comparatively, it is improved. But still, I'm lacking in my activity. Patient will feel in that way. I'm lacking in activity. I'm able to move comparatively, but still I couldn't. So the patient will itself create a negative feedback on his own. So if you gave yesterday how you comb your hair like this, after 15 days how now I'm able to comb my hair on my own. Now I feel better. I feel the patient will have the enthusiastic to do the movement. So always even your normal rehabilitation program itself. Now I'm not talking about the biofeedback. Even if you're talking about the normal biofeedback mechanism, muscle rehabilitation itself, always make the patient to train the activity which they couldn't do. Okay, so always in case of the CNS lesion, always make the patient to involve in the activity and your rehabilitation will be in achieving the goal. The patient who couldn't able to get up from the chair, okay, stimulate that particular muscle and making up to get up individually without any dependence, without any assistance. This is very common. Today, after so many years, today I got up on my own. Really, I feel very positive today. So patient really will help. Really, once a positivity has period in the mind, they'll go. They themselves come and ask you. So today we'll go for the this level of activity. Tomorrow we'll go for the this level of activity. I'm able to now do these activities. Now I'm going for a job. Now I'm going driving on my own. Now I'm able to walk down up and the stairs on my own without any support. Really, I'm improved better. Now I'll be all right with you within a month. So this positive, in this EMG feedback, not only the machine is going to interrupt, the command, the voice, okay, and the visual conception you're giving, okay, this plays a vital role. Okay, the command. If you connect the patient and just reach the goal, try to reach the goal, and if you said to make the patient reach the goal, and if you move off, definitely the patient will. Okay, the voice, the command, what you're giving, making the patient to move and interpret in the activity. So what we saw in the videos, you have to keep on giving the command. That's it. Good. Keep up. Come on. Oh, you're doing a really fantastic job today. Really, it's very good. And you have to give some rest in between, because if you give a continuous contraction, automatically the muscle go for a staticness also. So meanwhile, you have to go for the next level of the muscle, which is going to involve. Don't always activate a single muscle. Always go. You just take today these type of re-education is good. You just form a paper. What are the muscle has to be re-educated? First, you just put a graph. So today, these are the muscle has to get re-educated. Just at least minimum three to four muscles in a day re-educated. Then you just go for the next level. You just create a separation for the upper limb individual, for the lower limb today, for the back today, for the abdomen today, for the lower. You just separate in a column and make the patient to re-educate. Fine. So then we'll go to the visual rehabilitation. I think very few using the visual rehabilitation. In our clinic, we are going to establish the visual rehabilitation in a complete bigger way. So definitely not only for this neuro cases, even for the ortho cases also, even for the pain cases also, we will go for a rehabilitation. So in this way, this visual rehabilitation is going to play a very greater role over here. I have a software which you can analyze, the muscle capability, okay, how much strength it is, okay, how much strength in the sense not about the activity, how much power she can achieve. Today, this much goal she can achieve, tomorrow this much. So we can easily identify the power, and you can identify the range of motion of the particular joint. Okay, so if the patient is moving the forearm and taking a glass from the table, you can easily identify how much ROM is moving on the shoulder, on the elbow, on the wrist, on the eyepiece also. Okay, so we can easily visualize the ROM of the joints. Once we visualize the ROM of the joints, automatically we can make the patient. So which ROM is keep on. Some people will use only the elbow to move, just to pick up and down. Okay. Some people will don't move the elbow at all, only the shoulder will move to pick up the glass or whatever it is. Okay. So we can easily find out how much range of motion is achieved each and every joint. That in turn easily we can re-educate. If, for example, if the elbow alone is using, they are not using the shoulder at all. They are very small movement. So automatically we can re-educate the shoulder muscle to the particular shoulder muscle also to increase. We have a lots of range of motion exercise also. I'll show you the video. There is a lots of range of motion exercises also. So once it automatically you fix a goal, automatically patient will capture. They will try to move the joint and try to touch the object. Okay. So coming to the visual reality, definitely it's going to stimulate the patient's sense. Okay. So it will create an illusion. Okay, like a part of being man on sitting on the visual thing and trying to achieve a lot of things. Okay. So we have lots of technology in order to achieve the goals. Okay. It is in the sense of the perception as well as the cognition. Okay. How it is being used in the physical therapy. So you have a lot of motivating atmosphere. And these feedback can be controlled while retraining the movement. We have a positive feedback. So it makes the patient to participate in the game, both pleasing as well as you'll get lots of rewarding moments over there. Once if you achieve this much, you'll get this much of points, this much of smiling today. So patient will have a positive positive thing to move for the next level. If you like a child, if you make the child to if you make the child to just do this movement, definitely they won't. Okay. If you reward, if you do this movement, I will reward with you like this a chocolate or a toy. Definitely the kid or a patient will definitely will try to make it a movement. Okay. So in a patient and the therapist have to interact with the multi-sensory dimension environment. That is a real time where with each and every dimension, the perception has to get involved from the patient as well as the physiotherapist to get it involved and to reach the goal. Okay. So what are the patients? Stroke, arthritis, amputation, joint replacement, disc disease, bone injuries, post-op, osteoporosis, whiplash, paralysis, myopathy, neuromuscular dysfunction, peripheral neurology. We have lots and lots and lots. That's why most of our patients can use our physical rehab. Okay, making the patient coming regularly for the rehab session, doing daily exercise. Okay, what we'll do is we'll put a program. Okay, for a rehabilitation. One day it's completely under EMG. Okay, one day it's completely PNF. One day completely visual, and one day completely aerobic toning exercises. One day completely suspension therapy. So these different types of exercises makes the patient to motivate and to engage in the activity. If you give a simple exercises alone, making the patient, you just make the patient to do exercises regularly, coming to the clinic and doing the regular exercises. Definitely after some period of patient itself got very bored, and what they will do is, you just teach some exercises. I will do it in my phone. You just teach. I'll do it. Definitely what they will do, if you teach exercises, they will very vigorously, they will do it for 15 days, 20 days, automatically they won't. Okay. For a normal patient, doesn't matter. Think about the CNS cases and all. Definitely, they should have a motivation, especially in the neuro center. We should have these types of biofeedback missions. These biofeedback missions make the patient to engage, to optimize, and this is going to accelerate the recovery process very fast. When compared to the normal person who is engaged in the rehabilitation, we have a lots of recovery process. We will be very fast in accelerating to go for the next level of recovery. Okay. Why did VR work? Lots of working mechanism over here. This environment definitely is a controlled environment. Okay, it won't be uncontrollable. Okay, it's everything under control. If you want to move these joint movements only, it will be very controlled to move this joint again. Okay, there will be very practically simple tasks. And patient, if you able some, especially males and all, they want to do some complex stuff, don't want to simply achieve a simple task. Usually, females compared to the females, males are more very interesting in to reach the task. Okay, they want to achieve it. Okay, even females will have, but comparatively they have a lot of motivation, especially in our mother age group people. Most of them were the housewives. Okay, they don't have that much motivation to reach it. But males will have lots of motivation. If you give a good task, definitely they will. If you motivate them, definitely they will try to achieve that complex task. Okay, and you will get the data analysis complete report. Last month, these are the achievements have been done. These months, these are the achievements have been done. You can take a report, you can take a printout and give it to them. So visually they can see, oh, fine, comparatively I have a lot of tasks have been achieved. They themselves feel motivated. Okay. So they can engage in the sensory feedback necessary for the grasping capability. Okay. So it's a 3D environment created in a computer. You have a good physical interaction with the virtual environment. You will have a good relationship. So you even if they will talk to you, ma'am, you just reach, yeah, you reach the goal. So automatically there will be a visual feedback, auditory feedback. So patient will have a good mentality to go to for the to achieve the goal. Okay. Here the physical therapist role. This plays a vital role. Okay, able to properly incorporate this technique into our patient exercise program. That's very essential. Okay, you have to know how it has been achieved, how the different mechanism, how the different types of goals over here, how the task can be how the task can be created according to the patient. You have to get it updated. Okay, then slowly educate yourself. What is this technique is for? Okay, what is this virtual reality? How it has been used? Or you can use even with the small mobile, even you can use in the home also. But what is the role? You have to educate the patient. Then individualize the treatment. Yeah, you have to. I already said you have to specify the parameter of the exercise according to the patient needs. Okay, if the patient is able to go for the hip flexions about 0 to 10 degrees, then you couldn't fix an resistance or about making the hip to move for about 50 degrees. Okay, you have to make if we are able to do 10, you have to set a goal of about 50 degrees first, 10, 20 degrees. So you have to find out which is the patient needs. Some patients some patients will be very much involved in driving the two-wheelers or four-wheelers. Some patients will be very much. I have to sit a lot. I have to do a lot of business in my home. I couldn't nowadays. Even I couldn't sit for a long period of time. So you have to make the patient. So you have to identify the patient needs. What are the major activities they want to get it participated in a real life? So you have to identify the needs. Depends on that. You have to fix the activity. Okay, so making the patient to sit in a proper chair with a complete support. You have lots of cognition activity, balance training. So by giving a proper balance training and cognition activity through the virtual rehab, the patient will get it easy control over there. Then they feel, oh, nowadays I'm sitting and working for a long period of time. I'm very much satisfied in doing this. So this much of you have to create the abilities and the reactions to the complete program. Then finally, I will show you some videos. As a small boy, according to this boy, we have kept a very minimal side flexion. So you have to, yeah, you have just take once again. Slowly have to balance and automatically you have to move without any touching the interpretation behind us. So according to this, he is moving automatically. Okay. So here, for the upper limb, he is trying to take the neck and trying to burst in the ball. So according to that, his both upper limbs, the neck, the spine, everything is moving. Check off. The patient who couldn't be able to eat on his own. Automatically, he is trying to take with the spoon and moving into the mouth. So he can take a glass of water also and drink. Yeah, slowly he's moving now. I'm trying to take something else and continuous tools. Lots of things I kept over here, so you can use his arm. It's visually he will think that his arm is over here, so he will be moved into the device. Okay, so let's come to the end of the session. The biofeedback mechanism usually initially started with the diagnosing program only initially. Nowadays, lots and lots and lots of advanced things have been coming. So you can see lots of interpretation happening, lots of interpretation. So you can go, you just keep yourself updated. Still, not only now, not only this, we have still lots of updated things in the biofeedback. Each and every one has to get engaged and make the patient feel themselves to get it engaged and get a proper rehabilitation, make the fit to done it up. Okay, so that's it today's session. We have ended up with a good session, I think so. So if you have any doubts over here, we'll have a good interactive session to clear all your doubts.
Yes, ma'am. Thanks for the session. So,
Can go for now the question and answer session. Dear participants, if you have any question, please post in the chat box, and our Fitness and Rehab India live YouTube channel viewers also, they can post their questions in live chat box. We will convey the questions here to ma'am so that she can answer for you. Any questions you can post now.
yeah, ma'am. We'll see.
You can also unmute yourself and speak to our resource person directly.
Any questions, dear participants?
No doubt.
Yeah, I'm waiting for their questions or.
Yeah. I think some message has come. It's a thank-giving message, and question is there. Lucas, please read it out for ma'am.
Yeah, ma'am.
There is any visual impairment of vision, any eye related chat, I think so. In the chat box.
Yes, ma'am. There is a question, whatever you have read, ma'am, from.
Yes, of course. I said, not only there is a visual feedback mechanism, you have lots of auditory signals to reach. I said there is a lots of bell sounds. Once if you reached, okay, then you will get a glitter sounds, you will get a ring sounds. Once if you achieve the goal, there are a lot of auditory signals also in the EMG as well as the visual rehab. This is not only for the visual perception. I said it's a cognitive, balance training, visual, auditory, everything, all sense is going to get it aggregated. So usually the feedback is it's not only visual. Yeah.
Yes, ma'am.
Duration of VR session. It depends. I said, it's not based on only the muscle activity training. I said it's based on the ADL activity training. If suppose the patient came with you for the rehab for stroke, some people say, well, I have a stroke for about 3 months history of patient. The patient definitely will have a stiffness, spasticity in the biceps. There will be a fixed flexion deformity. The major goal is to move his arm and drink water. Okay, so first fire up the muscles, activate the muscles. See, what we'll do is we'll start with some, we won't give stretches, I don't want to explain all those, it will be a big session then. Okay, so don't stretch the muscles, first activate the muscles. We'll activate the muscles through PNF initially. Once if there is any activation potential created, we'll start Okay, we'll start. Here can be given to sports rehabilitation. Yes, first I'll finish up this answer question first. Okay, we'll start with the PNF rehabilitation. Then slowly, once the muscles got firing, automatically we'll connect. I said, one to the flexors, one to the flexor discorum superficialis and profundus, make them to contract and make the biceps to contract and make the shoulder adductors to contract and pectorals also. All together will make the patient move into the achieve this. So if the patient will have a good muscle strength and tone and as well as the good muscle strength and tone, okay, the patient you have to check how much counts can they able to achieve. For example, some people will have the capability of doing only 15 counts, their muscle will go for a fatigue. Some people will reach even 20 sets. Okay, it depends on the muscle firing. Okay, identify each and every muscle firing, identify each and the muscle power, then you go for to find out the how many sessions, how many minutes on that. Okay, and one more person asked for this can be done for a VR sports activity. Definitely, we have a VR sports activity. I don't have the video, but you can get it from the YouTube. You have an EMG sports activity also, and you have a lots of. I just given a small example. Okay, there is a lot of high jumps, long jumps. Okay, I don't know what to say. Even badminton playing. There are lots of sports activities also to get it achieved. This can be done for the to increase the strength and endurance capability of the muscles for the sports patient also. Any other?
Yes.
Any more questions, Rupesh?
No, ma'am.
One more has come, I think.
Yeah. Can
Okay, it is a Thanksgiving message for Madam from Dr. Mohammad Ishad Ali. Can we conclude then, Rupesh? No more questions, I think.
Yes, ma'am. So I take this opportunity to thank Kalpana ma'am for this wonderful session, which is very newer trend to be practiced in India, especially in Chennai. I guess very few sessions are there, and few clinical setups with VR will be helping most of the rehabilitations. I think so, ma'am. So with this, I thank ma'am and thank you JK Rehabilitation Setup, Ananagar and Kodambakam.
Completely, I have to convey one thing. We completely are going to open a complete neuro setup in the next 2 months. Okay, with advanced robotic rehabilitation, the complete. It's only precise for all the we have, especially for the neuro. The whatever I have already, we have a visual. We are planning to go for a robotic, and we have to go in for a gait posture lab with the EMG activities, all these things. So any person who are interested to get the knowledge, anytime you can walk into my clinic. I am very pleased to get and clear all your doubts. If you need any information about the meetings also, I will give you.
Thank you very much for this opportunity also, ma'am. So those who are in Chennai and Tamil Nadu can avail this very truthfully. So with this, we'll conclude this session and we'll meet forward in tomorrow's student session at 4:30 p.m. Thank you and bye-bye, ma'am.
Thank you, ma'am. Good night.
I'm very welcome.
Yes, ma'am.